Catholic Charities is taking this trauma-informed approach because it's something we really have to do if we're going to be as effective as we can be in providing all of our services to the people who come to us for help. So that 20 years of research that I mentioned, part of that was to recognize that everybody that comes to us, whether they're coming here because they're homeless, they're coming here because of child abuse, or because they have serious mental health issues, that we just know now that trauma is going to be in their background. And so we as an organization have to understand that and have to understand what things we need to change so that we can be as helpful as we can be. There's a catchphrase in doing trauma-informed work that goes something like, it's not about asking someone what's wrong with you, but about what happened to you. So I think if everyone can watch this workshop and have some appreciation for the effects of adversity and trauma on the folks that come to us for help and on our coworkers, that it creates a better understanding of the behavior, the emotions that go along with that, and that it isn't about thinking of someone as being sick or ill or bad or blaming them, but just trying to have some understanding that those things arise from people going through some really bad experiences.
This is the Trauma and Trauma-Informed Care Workshop. So a lot of the government agencies that fund us have transitioned to trauma-informed systems. The Division of Mental Health and Addiction Services, and that is a federal agency, has published guidelines and standards for trauma-informed care. And the New Jersey Division of Mental Health and Addiction Services and the Department of Children and Families are all moving forward with their trauma-informed care. And they expect and require that service providers will also become trauma-informed. But it's not just about the funding, and this is a short video to explain why this is so important.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California, and together, we opened a clinic in Bayview Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, "Dr. Burke, have you seen this?" In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you'll want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across the lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real, and this is all of us. I believe that we are the movement. Thank you.
So the ACE study was the Adverse Childhood Experience Study, and it's an ongoing study between the Centers for Disease Control and Prevention in Atlanta and Kaiser Permanente in San Diego, California. This is one of the largest investigations ever conducted to assess the associations between childhood maltreatment and later life health and well-being. ACE findings suggest that certain experiences are major risk factors for the leading causes of illness and death, as well as poor quality of life in the United States. The impact of adverse childhood experiences over the lifespan is tremendous. Maltreatment in childhood can result in impairment of the brain and physiological development, changes in the brain neurobiology, social, emotional, and cognitive impairments, and adoption of health risk behaviors as coping mechanisms such as eating disorders, smoking, substance abuse, self-harm, sexual promiscuity, violence. Early experiences help to determine brain structure, thus shaping the way that people learn, think, and behave for the rest of their lives. What is trauma? There are a number of definitions, but the one that I think is one of the best was published by SAMHSA in 2012, and it includes 3 key elements: Individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as overwhelming or life-changing, and that has profound effects on the individual's psychological development or well-being, often involving a physiological, social, and/or spiritual impact. The experience of violence and victimization includes sexual abuse, physical abuse, severe neglect, loss, domestic violence, and/or the witnessing of violence, terrorism, or disasters. We can break trauma down into two categories. One is acute trauma, which typically involves a one-time experience, such as a disaster or a car accident, or complex trauma, which usually involves prolonged or multiple traumatic events. Complex trauma typically occurs within a caregiving relationship by neglect, physical, sexual, or verbal abuse, and for a child will disrupt their feelings of attachment to others. So trauma is individualized. It is not the objective facts of an event that determine whether the event is traumatic. It's the way in which each individual internalizes the emotional experience of the event. Traumatic events or circumstances often have lasting adverse effects on an individual's basic sense of self, trust in others, physical, social, emotional, or spiritual well-being. Trauma is disabling. It can impact feelings, becoming emotionally overwhelmed, fearful, anxious, helpless, or quick to lash out and become defensive. It can impact thinking. People can't think clearly when stressed. They have trouble managing their anxiety or their distress. And it can impact functioning. The capacity to function every day in everyday life is impaired. Some consequences of trauma include over-control, self-blame, passivity, expecting and eliciting negative reactions from others, addictive behavior, self-harm, impaired attachments, and interpersonal skill deficits. Trauma can be overlooked because it mimics a lot of other conditions. A lot of the behavioral responses will resemble common disruptive behaviors and are often under-identified as trauma symptoms. An example of that is children who are diagnosed with attention deficit disorder sometimes actually have a trauma. Stress modification is different by ages, stages, and expression, and we often don't connect the symptoms and behaviors to trauma, and thus it leads to punishment instead of help. Therefore, we need to presume the clients we serve have a history of traumatic stress. Being trauma-informed also means that we recognize the effects of trauma and adverse experiences in our own lives and in our coworkers. When an organization takes the steps to become trauma-informed, every part of the organization, management, administration, and support and service delivery is assessed and potentially modified to include a basic understanding of how trauma impacts the life of all the individuals in the organization. In a trauma-informed system, trauma is viewed not as a single discrete event, but rather as a defining and organizing experience that forms the core of an individual's identity. Sometimes what we do actually re-victimizes, so any interaction or personal encounter that recreates aspects of previous traumatic experiences or that uses power to punish is harmful to the individual involved. So what is trauma-informed care? It's building trusting relationships with the individuals we help and with our coworkers, telling people what you're going to do before you do it, seeing trauma responses as adaptations rather than manipulations, and teaching and supporting the person to learn ways to manage emotions. How would people be treated in a trauma-informed environment? We would see them recognizing that the function of behavior, even rage, repetition compulsion, and self-injury is adaptive. So people develop behaviors in a way that helps them to survive, even though they may seem maladaptive to the person viewing it. The individual is the center of treatment in a trauma-informed environment. Power and control is minimized. Constant attention to practices. Language is person first. So we don't talk about victims, but someone who was victimized. And it involves training of all staff to improve knowledge and sensitivity to trauma-informed issues. What is resilience? Resilience is remaining stable with healthy levels of psychological and physical functioning in the face of disruption or chaos. the ability to adapt to stress, adversity, trauma, or tragedy. And resilience can be learned. It's not necessarily an inborn trait. How to become more resilient. There are certain behaviors and things that we can practice that help us to become more resilient. So we can practice overcoming hurdles in everyday life, having a purpose or finding a purpose, accept reality with a positive attitude, learn how to improvise, meditate, so any mindfulness training, exercise, developing an abiding sense of humor, building strong support networks, keep your mind flexible, face your fears, reframe, so we can reframe negative things in a more positive way, nurture a strong sense of self, know when to be kind to yourself, and be compassionate. What are some of the values of trauma-informed care? They include dignity and respect for a person, not blaming, so what happened to you rather than what's wrong with you, a holistic approach. The person is seen as the totality, not just of their behaviors of the moment, and learning and support for self-care and wellness. So kindness goes a long way. Everyone you meet is fighting a battle you know nothing about, so be kind, always. Vicarious trauma. Trauma-related stress reactions and symptoms resulting from exposure to another individual's traumatic experience can cause vicarious trauma. The demands of caregiving exact a price from behavioral health professionals that cannot be ignored. Protective factors include training on trauma-informed care, emotional support from colleagues, and good self-care. So some self-care things include sleeping at least 8 hours a night, eating nutritious foods, exercise, practicing good boundaries, and using positive coping mechanisms versus negative coping mechanisms. Understanding trauma is imperative because trauma is pervasive. Trauma's impact is broad and diverse. Trauma's impact is deep and life-shaping. Trauma, especially interpersonal violence, is often self-perpetuating. Trauma affects how people approach services, and the service system has been re-traumatizing in many cases. Healing is possible. So in summary, a lot of the funding sources that we have, the Division of Mental Health and Addiction Services, the Division of Children and Families, and our own agency are all changing to trauma-informed systems of care. Trauma impacts people over their lifespan. Trauma is individualized and results from an event that is experienced and has profound effects on that individual. Trauma impacts how we think, how we feel, and how we behave. Trauma's impact may look different with different people, and trauma is so common that we need to presume that everyone we interact with may have a history of trauma. We want all staff to be able to approach people with the same language and the same understanding of trauma. Any interaction that recreates aspects of trauma is harmful, and we want to be careful not to re-traumatize anyone. Trauma-informed care includes building trust, telling others what we are doing before we do it, and supporting others in managing their emotions. Trauma-informed care environments include safety, they're welcoming and comfortable, power and control is minimized, and there's a collaboration between staff and those we serve. We will be saying things like, what can I do to help? What do you need? What happened to you? Instead of what's wrong with you. Staff should be even-tempered, have a calm approach, and compassionate concern. The benefits of this will include increased safety, increased quality of care, increased work satisfaction, increased organizational wellness, and reduced negative interactions. And this is a website to find out more about trauma-informed care.